Thank you, Esther, and thank you everybody for joining us today. So today I'm going to talk about a life course approach to menopause, and this is the third in the series of talks following up from those great presentations from colleagues Emma and Eve over the last 2 weeks. So I'm really excited to be giving this presentation. It's the first that I've given since joining Loughborough. I joined Loughborough University only, less than 3 months ago. And this is the first talk that I've given as part of Loughborough. Prior to that, I spent nearly 30 years at the University College London. And I'm an epidemiologist and medical statistician by training. And I've spent over 30 years of research looking at a life course approach and particularly applying that to healthy aging. So in this talk, I'm going to first of all introduce what I mean by a life course approach. So just so that you all understand sort of where I'm coming from and so we're all on the same page. I'm then going to apply a life course approach to menopause. I'm specifically thinking about that in relation to the timing, the age at menopause, and also midlife and menopausal symptoms. And then I'm finally just going to talk a little bit about what this means for the management of menopause. So first of all, starting off, what do I mean by a life course approach? Well, a lot of disciplines have a life course approach, but I'm going to specifically talk about a life course approach in epidemiology. As I said, I'm an epidemiologist and medical statistician by training. So I study the patterns of disease and the causes of disease and aging. And so life course epidemiology investigates the long-term effects on these chronic disease risks or on aging of both biological and social exposures. And that's really important in life course epidemiology because as well as talking about biological risks such as smoking or pollution exposure, we also think about the social risks such as poverty, socioeconomic disadvantage, for example. And while a lot of epidemiology just focuses on exposures during adulthood, such as health behaviours, activities, smoking during adulthood, life course epidemiology looks at exposures at all different stages of the life course, including gestation, so that's in utero life and development, as well as childhood and adolescence, and even across generations. Now, life course epidemiology was coined by Professors Diana Koo and Yoav Ben Shlomo initially back in 1997 in the first of this series of books that you can see on this slide. And I worked with Diana Koo for over 25 years until her recent retirement. So I've been involved in the development of a life course approach in epidemiology for a long time. And at the moment, little plug here, I'm currently in the final stages of co-editing the second edition of a life course approach to women's health, one of the books that you can see at the bottom there. So that will hopefully be coming out this year. So as well as looking at biological and social exposures at different periods of the life course epidemiology is also interested in the pathways that operate across life. So some of these exposures in early life may not be directly impacting health in later life, but may set off what we call a chain of risk that then leads to a poor outcome. And so it may be an indirect effect as well as direct effects. So it's also interested in looking at chains and pathways across the life course. Another key concept in life course epidemiology is the idea of function. Now, a lot of epidemiology studies chronic disease as an outcome, and chronic diseases tend to happen at older ages. Age is by far and away sort of the biggest risk factor for many chronic diseases that people suffer. But we can measure bodily function, we can measure function across the life course, which might relate to these diseases. And epidemiology is all about trying to prevent disease. Prevention is better than cure. So we're looking for opportunities in the life course and the right point in the life course to be able to intervene to prevent or delay the onset of chronic disease. So a lot of functions, bodily functions, look like this. This is a schematic diagram of that. But we have this developmental period in early life. We have a peak or a plateau in early adulthood, and then we have age-related decline. And you can see from this schematic diagram here that the way that people age and where we hit this threshold, which below this is where disease occurs. So this is sort of preclinical phase of disease, but we can get to this in multiple different ways. So we might have a low peak or a high peak and different rates of decline. So this immediately says, well, actually, we need to look early in the life course to promote that peak development, as well as looking later in the life course to look at what might influence the rate of decline. Now, there are many functions that do look like this, and just to prove that they actually do in practice look like this looks at grip strength, a measure of muscle function over the life course. And you can see indeed that we have this phase of increase, peak, and then age-related decline. And of course, there's variation across the population, across people, in terms of their grip strength over the life course. And we might like to think about reproductive function in terms of this across the life course as well. Other functions that follow this pattern are lung function, and also many types of cognitive function and other types of physical function as well. So we often end up drawing diagrams and thinking about life course epidemiology like this. So I'm using the example of lung function here, which, as I say, follows that sort of pattern that you've just seen. And at the far end of this, once lung function declines enough, we get disease, which needs to be treated. So here we can see that we look at early life. We might have poor growth in utero and early infant respiratory infections, which lead to poor lung development. So that means that we're not reaching that peak lung development in early life. We also then have this more social pathway from disadvantaged childhood, socioeconomic position, which are related to exposures, which are socially patterned. So for example, people who are more disadvantaged tend to live in areas where there's greater air pollution, or do jobs where there are greater occupational hazards, exposure to chemicals, for example, which lead to more rapid lung decline. Okay, and so life course epidemiology is quite challenging because we've got all these interrelationships across the life course, and we also need studies, we need data to be able to test life course ideas. So we need studies which follow the same people across life, and we need these to be quite big studies as well to be able to study these relationships. Now, a birth cohort study is the ideal type of study, and these follow people from birth right throughout their life course. So we're very lucky in the UK to have multiple British birth cohort studies. And these are people born in 1946, 1958, 1970, and the most recent one is at the millennium, although there is a new one that is being planned at this moment. And then they study these same people across the whole of their life course. And I worked on the first one of these, the MRC, National Survey of Health and Development, for over 25 years. And these people, as you can see, have been followed up sort of well over 20 times now, and they're now into their 70s. They've been followed up since birth. So these are really incredible studies. And we also have other longitudinal studies which follow the same people, but not from birth in the UK and around the world. So these are the resources that we use for life course epidemiology. So I'm now going to turn to the topic of today and thinking how we can apply this life course approach to understanding menopause. So Emma and Eve both highlighted these basic characteristics of menopause, but I'll just go through it again for those that weren't on those previous calls. So menopause is a natural transition. It occurs around about the age of 50 to 52 is about the median age of menopause in high income countries such as the UK, and I think it's about 51 is the estimate currently in the UK. Most women go through menopause between the age of 45 and 55, and we define premature menopause as women who undergo menopause before the age of 40, and early menopause if it's before the age of 45 and more than 40. Now, interestingly, the median age is different in low and middle income countries. So it tends to be earlier in these sort of more disadvantaged countries. So suggesting that there are environmental conditions that impact the age at which a woman goes through menopause. And just to highlight that we define postmenopause after 1 year without menstrual periods, and then that the perimenopause is the period that occurs before that, where you often get changes in the regularity or the characteristics of menstrual cycles. So we know that perimenopause and menopause are these times of declining levels of estrogen. So previous speakers have talked about the protective effects of estrogen, which might explain the better health of women prior to menopause. And you can see on this graph how sex differences in blood pressure, the sex difference, the sex advantage that women have in having lower blood pressure over much of the adult life course decreases towards older age. And this sort of decrease and this narrowing of the gap between males and females coincides with the menopause transition. So if we think that exposure to these reproductive hormones is protective for many later life health outcomes, then exposure to these reproductive hormones clearly varies across women themselves, and it varies therefore depending on age at menopause. So if we have sort of an over 10-year difference in the age that a woman reaches the menopause, then the cumulative exposure over the life course is going to vary. So we can get insight into the impact of reproductive hormone exposure on health by studying how age at menopause influences health. So there's been a huge amount of research looking at this, not all consistent, but in general, reviews of the evidence suggest that earlier age at menopause is related to an increased risk of osteoporosis and bone fracture, so poor bone health, and also to an increased risk of type 2 diabetes and cardiovascular disease. And Emma talked about the cardioprotective aspects of estrogen a couple of weeks ago. However, on the other hand, later age at menopause is related to increased risk of some cancers, so breast, endometrial, and ovarian cancer. And this also makes sense because it's greater exposure, higher levels of hormones that are related to these diseases. Now, there's been a lot more publicity about the impact of menopause, not just on health, but on social characteristics, social and work and employment. So this is some work that I did recently with colleagues at UCL. And we showed that early natural menopause reduces the number of months in employment once a woman gets to her 50s, but only by a few months, not by a huge amount. And the early menopause, it was rather related to part-time employment rates rather than full-time employment rates. But what we didn't expect to see was, and that's what's illustrated on this graph, was that women who had an early menopause had different employment rates prior to menopause as well. So you can see here they had lower employment rates prior to menopause as well as sort of later on and after menopause. So this gives us a little clue that we need to take a life course approach. We need to look further back into the life course to see what's happening here. However, symptoms had a greater impact than timing of menopause, early menopause, on employment rates. But interestingly, it was the psychological symptoms that were associated with employment rather than the vasomotor symptoms. And these are the classic menopausal symptoms that are the hot flushes and the night sweats, which others have spoken about in previous weeks. So we know that we've got these sort of things that are related to menopause, symptoms, subsequent health, symptoms are related to work. But if we're just studying menopause and subsequent health, we're starting looking at health at the age of 50. So I argue that to really understand what's happening in later life, we need to look at those previous sort of approximately 50 years, and that will shed light on helping us understand what happens at menopause and beyond. So I'm first going to talk about age at menopause. So why are we going to take a life course approach here? Well, as I said, that in low and middle income countries, the age at menopause tends to be earlier than in high income countries, which suggests that there are factors which affect the timing of menopause. And why should we go right back to birth? Well, a woman is born with a finite lifetime supply of these primordial ovarian follicles, which have the potential to then develop into oocytes. And even before menstrual periods begin, those follicles are lost, or some of those follicles have lost. And by menopause, these are depleted. So we want to understand perhaps what influences the original supply of follicles and that decrease before menstruation starts. Okay, so there's been some research looking at what factors are related to having an earlier menopause. And there isn't a huge amount of consistency, but sort of summarizing, we do know that genetics is important. So that is something that's strongly inherited. So mothers and daughters menopausal age is correlated, and there is a genetic effect, but obviously we can't change that. So there is room for these environmental factors to influence age at menopause. So disadvantaged socioeconomic position, smoking, low body weight, not having children, and shorter menstrual cycles have all been shown to be related to earlier menopause. And I've just put some nice work here that's looking at more detailed analysis of smoking and early menopause. And you can see that the age of starting smoking, so if you start smoking earlier, you're more likely to have a premature or earlier menopause, and if you start smoking later. But the good news is that if people stopped smoking, then their risk greatly decreased, as you can see here. And just highlighting these last two, not having children may not actually be a causal relationship with age at menopause, but it may highlight some poorer ovarian function or infertility across the life course. And so early menopause and not being able to have children might be a consequence of this same underlying health or functional trajectory. So looking at early life factors related to earlier age at menopause, and this is, I've done quite a lot of work here, but there's very few studies that are able to do this, that have the data from early life and then looking at age at menopause. So the evidence here is much more sparse. We do, however, know, carrying on this sort of reproductive characteristics theme, that early age at menarche is related to an earlier menopause. So here, highlighting this really nice paper, highlighting these interrelationships between reproductive characteristics across the life course, highlighting that we can't just look at the menopause transition in isolation. There's also evidence that potentially poor early growth and nutrition and adverse childhood experiences, really harsh adverse childhood experiences such as abuse, but also sort of stressful adverse childhood experience such as experiencing parental divorce. And we know that sort of early life stressors can influence the stress response and hormones throughout the life course. So there is a mechanism as to why these early life stressors might have long-term impacts on reproductive function. Then I just want to mention some work that sort of has been an ongoing interest of mine, going right back to 1999. So working with a cognitive psychologist, Marcus Richards, he was interested in looking at the impact of menopause on cognitive function, but sort of stumbled across this finding that childhood cognitive ability was associated with the age at menopause. So here, lower childhood cognitive ability, assessed at the age of 8, was associated with earlier menopause in this 1946 British birth cohort study that I spoke about at the beginning. Now, I should emphasize here that we're not talking about cognitive impairment. We're talking about small differences. We're talking about cognitive ability within the normal range. And we're talking about quite small effects. But obviously, this is fascinating because it suggests this interrelationship between cognition and reproductive function. And we thought this might just be a chance finding. So we tried to replicate this in other studies. We immediately were able to replicate it in a Scottish study. And then just recently working with other colleagues at UCL, we've replicated it in these more recent born cohorts. So again, I'm not saying that cognition causes menopause, but what's more likely to be going on is that we've got some unknown or as yet unknown factor, which might be genetics, it might be hormone exposure in utero, which influences both development of the brain and cognitive function, and also development of reproductive function. Therefore, we seem to get this relationship between cognition and menopause, which therefore makes it challenging to study the association between age at menopause and cognition. And now we have looked at this in the 46 cohort, and we do see some effect of age at menopause on cognition in addition to this continuity of function. So what a life course approach is suggesting here is that we've got this tracking of two sorts of function across the life course, and we need to be able to understand their interrelationships to properly understand the impact of menopause on cognition. And there's been a similar argument that underlying cardiovascular health trajectory is also explaining the association between age at menopause and cardiovascular disease. So there is some evidence that early onset cardiovascular disease is related to early menopause. But obviously, there's not many women that have cardiovascular disease prior to menopause. And so the evidence supporting this hypothesis currently is not strong. So the question is still, does cardiovascular disease precede early menopause? We don't know that currently. But just thinking about, therefore, that we have all these risk factors that influence age at menopause, and you can see that some of them, not all, but there are some that are very overlapping with risk factors for cardiovascular disease and dementia. And I know Eve talked about the similarity of risk factors for dementia that are very similar to those for cardiovascular disease. So you'll have noticed we've got disadvantaged socioeconomic position, we've got smoking, we've got adverse childhood experiences, we don't have BMI, it was low body weight that was associated with earlier menopause. But when we're looking at observational studies, we therefore have to adjust for all these characteristics to try to isolate the effect of earlier menopause or menopausal age on cardiovascular disease risk. And this is a paper that I've been involved in, and it's a big consortium. It's called the Interlace Consortium, and it's about 12, 15 longitudinal studies all around the world that are brought together and pooled to try to get definitive answers on some of these questions. But here, because it's observational, we can't randomize women to have an earlier or a later menopause. We have to rely on observational data, but it means we have to adjust for all these prior risk factors that might be influencing timing of menopause and cardiovascular disease. So here, I'm just looking down here, we've adjusted for ethnicity, education, body mass index, smoking status, hypertensive status. But we might not be adjusting as well as possible. There might be other factors that we've not adjusted for. So this is always the challenge with observational studies. Nevertheless, what this does show, is it's a huge number, we can look in great detail, that earlier menopause is associated with increased cardiovascular disease and its components, coronary heart disease and stroke. So you can see these sort of trends from earlier menopause to later menopause here. And we could also look at hormone replacement therapy, or as we now call it, menopausal hormone therapy. And you can see that there was no difference in risk for hormone users for a given age at menopause. However, more recently, we have these new approaches that purport to get at a more causal effect. They aren't subject to those biases that I've talked about, where you need to adjust for multiple factors. So these uses genetically determined age at menopause, which, as I say, isn't subject to confounding, and sees how age at menopause is related to coronary heart disease. And this very recent paper is now showing, actually, they're suggesting there is no causal effect of age at menopause on coronary heart disease. So again, we're accumulating evidence all the time, and we have to update sort of our theories as new research evidence accumulates. As I say, that's very new and needs looking at and reproducing. I'm now going to move on to look at symptoms. So I'm going to use quite an old paper that I did with Diana Koo. So this was in 2005. So excuse the scrappy graphs. We could do much better now, but hopefully you'll get the idea if I walk you through this. So in the 1946 British birth cohort, we asked the study members to report symptoms every year. So we have annual data as they went through the menopause. A whole list of symptoms that they could say whether they'd experienced this in the last year. And then we grouped these using the statistical method. We grouped these into vasomotor symptoms. So those are the hot flushes and night sweats, sexual difficulties such as vaginal dryness. And then we have other sort of somatic symptoms, which are these sort of aches and pains and hair loss and skin wrinkling, those sort of things, and more psychological character and symptoms such as depression, anxiety, low mood. So we looked at how these varied according to the menopausal status of the women reported, but also some other characteristics. So we can see that for the hot flushes and the sexual difficulties, we can see that these were far more likely. So this is the sort of null line. So if we're looking this side, this is saying that these people are more likely to have these symptoms. So you can see that those who were perimenopausal, postmenopausal, women who had had hysterectomies and who were HRT users had higher risk of these types of symptoms. We can see not quite such a clear pattern in terms of the somatic and the more psychological symptoms, although it seems particularly that women who had had a hysterectomy or HRT users had a bit of a higher risk of such symptoms, but not as strongly patterned as those other ones. For those psychological symptoms, concurrent life stress, either at work or in family life in the last 12 months, seem to show a big increase in risk of those psychological symptoms. And then looking at some of these prior characteristics that we looked at, so we looked at prior anxiety and depression, prior health problems, smoking behaviour and educational qualifications, we can see that those with lower levels of education were at higher risk of vasomotor symptoms, so the hot flushes. Health symptoms or health problems reported prior to menopause were associated with a higher risk of these somatic, sort of more physical symptoms, and prior anxiety and depression was associated with these psychological symptoms at menopause. Therefore, we often attribute these symptoms that we experience at the time of menopause to menopause, but what this research and others has shown is that concurrent stresses or social factors might also influence symptoms. Menopause coincides with the time of life where women are also experience other transitions potentially. So you might have children leaving home. You will have older parents or older relatives who you might have caring responsibilities for. So there are all these other social changes that are also going along with that biological change. So that's really key in a life course approach, is to think about the biological transition, but also think about the social context in which it's occurring. And so these might influence symptoms. Of course, we don't know which direction these might be in, because symptoms and having menopause might also increase work and family stress. We also have things like health and education that are influencing symptoms. So you can see that it's a more complex picture than just menopause influencing symptoms. And we might have interrelationships between symptoms. I think Eve talked a bit about this, but this was a nice paper looking at how difficulty in sleeping might explain the associations between hot flushes and subsequent depressed mood. And there was also an association in the reverse, prior depressed mood influencing vasomotor symptoms. And sleep difficulties largely explained this first association between vasomotor symptoms and depressed mood, but it didn't explain the association between depressed mood and vasomotor symptoms. So again, taking this longitudinal approach, we can try to sort of tease out the associations among these symptoms. Another way of doing this is to look at subgroups of women. Now, not all women experience menopause in the same way, and not all women experience symptoms. And this is again using the 1946 British birth cohort study, where Mishra and Koo tried to identify subgroups of women who had similar patterns of these vasomotor symptoms. Now, the first graph here is looking at symptoms by age, and you can see not that interesting in terms of the patterns. And what's more informative is to look at it by what we might term menopausal age. So here, the 0 is when somebody is defined as being menopausal. And so prior to that is the perimenopausal period, and then this is the postmenopausal period in years. So ideally, we'd like to have more years than this, but this was all that was available, even in the 46 cohort, which, as I say, is quite unique at collecting these symptoms across menopause. So with these hot flushes, night sweats, we can see that good news is that nearly 50% of women don't experience very severe symptoms. Whereas the other women, there are patterns which you can see do vary by menopause. So we do see a peak and a decline in terms of when they reach menopause. But you can see that some women actually, there's a group of women who experience symptoms in the perimenopausal phase, and then they drop off quite quickly after menopause. There are others where the symptoms seem to peak at menopause and carry on into the postmenopause. So you can see that normal symptoms might vary across women. Just wanted to contrast this with the patterns for psychological symptoms. So exactly the same sort of plots here, that here, according to menopausal age, there were 5 groups. And what you can see is that there's more of a tracking of symptoms across that whole period. There is actually only one group of women who see a peak during the menopause and a decline, whereas these others are much more about tracking of symptoms across the life course or across this part of life. And you can see that there's even one group where actually the psychological symptoms seem to be improving. So this suggests that perhaps, there are a group of women where psychological symptoms are a direct result of hormonal changes at the menopause, but these other groups might be more about that you've had other psychological problems prior to menopause. And this obviously has implications about how you might manage those symptoms at menopause. So I'm just going to now finish off a little bit and talking about hormone therapy, as I know it's a topic of great interest to a lot of people. So who uses it? And I think Eve talked a bit about this last week. Well, in studying hormone therapy, unless we do randomized controlled trials, which Emma and Eve both talked about, if we're studying the effects of hormone therapy, there's a huge number of characteristics of why women who use hormone therapy are going to be different to those that don't. So the type of menopause, we know that if you have a hysterectomy, then you should take hormone therapy at least up until the age of natural menopause. The symptoms experience will, of course, influence whether you want to seek help for menopause. And also the age at which you go through menopause may have an impact on whether you decide to take hormone therapy. Your relationship with your GP, your healthcare provider, how often a woman goes to her GP, whether she seeks help, and the experience and the biases of the healthcare provider may also impact what you're advised to do. Then there are also these individual characteristics of women's preference for taking hormone therapy. Now, these do vary by time and place. So the older US studies showed that users were definitely healthier. And that was probably why we saw all these original studies showing the benefits of hormone therapy on subsequent health. However, in the 46 cohort, the UK study, they were actually, when we looked, more likely to be smokers and more disadvantaged. So the characteristics weren't that these women were necessarily healthier. However, that was before these trials, which seemed to show harm of HRT, were published. And so characteristics of users may be different again today. So this is the sort of diagram that I've shown so far, but obviously we can then add in all these other relationships and look at hormone therapy. And therefore you can see how difficult it is to isolate that effect of hormone therapy on health. And the other thing that we need to consider is that when we're talking about evidence and the recommendations for hormone therapy and management of menopause are based on research evidence. Well, that is all based on the average. It's based on risk. It's not based on the experience of an individual woman. And this is true across all of medicine, in that we're basing evidence on averages and differences in risk. But a clinician then has to make a decision when they have an individual person in front of them as to what would be best for that individual. Okay, so we must always consider that we're making generalizations despite the fact that treatment is for an individual person, and an individual person may respond differently to that treatment. And we can't predict very accurately at the moment who responds well to an intervention and who doesn't. So this sort of leads on to this idea about the medicalization of the menopause, and Emma touched on this in her talk, thinking about the narrative of menopause. I think it's great that we're talking about menopause more, and particularly about the challenges of menopause in the workplace. However, I think there is also a danger that we talk about the negative impacts, and a lot of the narrative is all around treatment of menopause and treatment of menopausal symptoms. But I hope I've shown that some of those health effects that we see at menopause may not be directly related to menopause. And as you saw from the subgroup analysis, there are some women who don't suffer symptoms very much during the menopause. We can also see it as a positive time. There are positives that happen at this time of life. So, for example, we don't have to deal with periods anymore. We don't have to deal with contraception. We might have children leaving home. That might be a negative, but it can also be seen as a positive, that you can reevaluate your life and do something for yourself. So I found this really nice, very recent paper about normalizing the menopause and how the medicalization is not an illness, it's not a medical condition, it's a natural transition. So we don't want to medicalize the menopause transition, which might then fuel these negative perceptions for women. So just to finish off, why do I think a life course approach is important? So that was sort of the second part of my title. So I think it can identify characteristics for which we can then adjust for in studies when we're looking at the impact of menopause on health. This is quite a sort of a boring reason to think about the need for a life course approach, but it does help us understand what we need to adjust for and the potential biases that can occur when we're trying to isolate the impact of menopause or any management or treatment of menopause on health. More importantly, and perhaps more exciting, I think it can improve the understanding of the underlying mechanisms and etiology of menopause. For example, perhaps if we can understand what's underlying that relationship between cognition and ovarian function, that might highlight some as yet unknown mechanisms of menopause. And it can improve the understanding of the variation of experience of menopause. So act as an education for women themselves and also for healthcare providers to understand the variation of experience that occurs at menopause and the characteristics that might influence that. Then leading on from that, if we understand these things, I think it opens opportunities for prevention. So opportunities for identification at those at risk for early menopause or symptoms of menopause, and we can start doing things earlier. So Eve talked about soy, and Emma talked about exercise. These are all things that can be done throughout the life course, and if we can understand those interrelationships of reproductive characteristics across the life course, then there are real opportunities to improve health across the reproductive years and into menopause. Now, I talked about this problem that all evidence and recommendations are based on risks and averages. Well, perhaps the life course approach can also help us to think about individualized management of menopause. And there's a lot of interest at the moment in medicine about precision medicine. And so, for example, basing medication and treatments on genetic risk, for example, or prior risk. So certainly in the field of cancer treatment, in breast cancer treatment, this is being realized. But obviously in terms of menopause, we're not there yet. We don't have the extent of research or evidence, but it does open up that possibility. And at least we can consider sort of our prior risks. If we understand what our prior risk factors are saying, whether we're more at risk of cardiovascular disease or breast cancer, then we can make more informed decisions, for example. And just to show that a life course approach, is really being thought about in terms of policy, this is really exciting that the new government's vision for a women's health strategy for England, which just came out at the end of last year, specifically talks about a vision based around a life course approach and around 5 key themes which connect different aspects of women's and girls' health across the life course. So I just wanted to finish off with that as a positive way of thinking about women's health and reproductive health across the life course as a whole, as well as just specifically looking at menopause. And the final graph or the final diagram on there is from, again, my colleagues Geeta Mishra and Diana Koo, who illustrate a life course approach to reproductive health and how we might start to think about that. So that really ties in with this vision of this women's health strategy. So I'm really excited and hope that this will be put into practice. So I'm going to finish there. So thank you for listening, and I'm happy to take questions.
Thank you very much, Rebecca. That was a really, really interesting talk. If anyone does have any questions, if in the first instance, if you could raise your hand, so you can find the raise hand option under the reactions tab, and then you can speak to Rebecca directly and ask your question. I think we've got someone raising a hand already. So Juliet, would you like to unmute and ask your question to Rebecca?
Thank you. Thanks so much, Rebecca. That was so interesting. My background's actually in life course epidemiology, so I was really pleased to see that you joined Loughborough, although I'm in social policy now. But yeah, it's nice to have a kind of somebody who does the same sort of thing. my question was actually about the employment research. I guess being in social policy, that kind of jumped out at me a bit. I just wondered if you'd looked at whether the type of employment that people had, as in the sort of organisation people worked for, whether that had any impact on those relationships, and also how that interacted with their reproductive history, because obviously that will affect people's working lives and their menopause symptoms. So yeah, just those kind of interactions, I guess. Yeah.
We didn't, but interestingly, just after this, I'm meeting with those co-authors again, because we did get approached by various organisations who are now writing or in the process of writing policies for workplace management of menopause. And one of the things that they're really interested in is what types of employment are, do women find it difficult? For example, if you're working in the NHS, for example, then it might be a real challenge to manage hot flushes and menopausal symptoms.
Yeah.
So no, we didn't, and so we are trying to find some funding to then look at that, because there is real interest in that.
Yeah, I would be really interested to hear if you do manage to do it.
And I think, and your second question, I think ties in with this whole life course approach, that we can't just treat menopause in isolation, that we do then need to have policies that are looking at reproductive characteristics in the workplace, and we do need to have that joined up thinking.
Brilliant, thank you.
That's great, thank you very much, Juliet. Helen has also got a hand up. Helen, would you like to ask your question?
Yes, thank you. A slightly random one, Rebecca. I noticed in the slides the later menopausal onset with the cancer indications, particularly breast and ovarian. Are you aware of any studies that look at the correlation between fertility treatment, IVF treatment, and ovarian cancer, and that menopausal link at all?
I can't think of any off the top of my head, but there is certainly a lot of research on various hormonal related characteristics throughout the life course in relation to these more reproductive related cancers. So unfortunately I can't specifically answer that, but there is a lot of research out there. So there are people like Valerie Beryl, who has sort of spent her whole career looking at hormonally related exposures in relation to these cancers.
Great, thank you. Thanks very much.
That's great. Thank you very much, Helen. Eve has got her hand up as well. Eve, would you like to ask your question?
Thank you. That was such a great talk, Rebecca. Thank you. I mean, lots of questions, but as it is the case always with this field, it's like you think, oh yeah, okay, I've got this now. And one of the questions I had was, you showed those data about women, who experience early menopause already spending less time in full-time employment in their 20s and 30s. So I thought, is that maybe because they've had kids early doors and we're staying at home moms, but then you said not having kids is actually associated with earlier menopause. So that kind of contradicts that. So do you have, apart from maybe that being a question that you raised yourself, do you have any comments on that?
So we did this work with Alex Bryson, who's an economist. So he used this approach that he said, we've got to get rid of this difference pre-menopause. And so we were doing all this work looking at the factors that are related to early menopause, and he's basically has thrown everything at it and still sees this difference.
Right.
It is only one cohort. It might be different in other cohorts. It could be a cohort effect, that something we don't quite understand. But I imagine it could be something to do with reproduction, because yes, when you're talking about not having children, you've got some women who are probably more advantaged who decide not to have children, and then you've got women who can't have children, that's the infertility. And so in a lot of these studies you can't distinguish those two sorts of women. Another way that you might, which I've tried in the past to distinguish who's having fertility problems, is if there's long gaps between having children or if they're just having one child. So that might sort of partly explain part of that potential discrepancy. But the answer is we don't really know why. It was a surprise.
Yeah, it is surprising. The other question I had, if I may, is you said that in the 1946 cohort, I remember that data, taking HRT was associated with being more likely, because I showed that Matthews paper showing the US data. Would that be maybe related to, and I'm sure you checked for this, I can't remember it, women in the UK being more likely to take HRT of the 1946 birth cohort because having undergone surgical menopause, hysterectomy, and that kind of linking in with the Canadian data showing that women who'd undergone surgical menopause and hysterectomy were more likely to be unhealthier as a result.
So it's not entirely due to that. So we do show that in women who are undergoing natural menopause, but you're quite right that, and in fact, we had a paper where we looked at the social gradient in hysterectomy, which interestingly also changes over time.
Oh, okay.
So initially it was sort of more advantaged women who were having hysterectomy, and then it has changed to more disadvantaged women who do tend to be less healthy. So we know that hysterectomy is related to poorer health. So there was some of that the gradient for that had changed, the social gradient had changed in the 46 cohort, but not entirely.
Wow, that's fascinating data, and the sort of socioeconomic factors that change over cohorts, and
by country, because obviously US, they were probably paying for their treatment, weren't they? Whereas this was before the trials came out. So we did actually look at who gave up when all that publicity came out. So the prescribing was probably very different at that period of time for that cohort. So it really does vary on sort of the recommendations at the time, the healthcare situation. I'm sure there's something we can do sort of comparing these different ones to actually perhaps tease out sort of effects of menopause using those differences.
Yeah, fascinating interaction that, and but not very straightforward at all, I guess, from the data you've shown. Thank you so much. That was very illuminating.
Thank you very much, Eve and Rebecca. Just one question in the chat that slightly off topic, but you may know the answer. So people are requesting, if you want to speak to a GP about getting some blood work done to identify where in the menopause cycle you are, what would you request or ask for further investigation?
Well, I think it is, I think it's a good thing that, there is this publicity around menopause, and, we hope that GPs, healthcare providers are, more trained in this. I don't know what the current, I'm not medically trained, so I don't know what the current advice is, but go and talk to a GP, try and find one who specializes in menopause. And then you can talk to them and talk about whether you do need to go through investigations. I think often, it's not actually necessary particularly to go through these investigations. If you're a particular age, it's more likely that if you are having an early or premature menopause, then that's where that might be more needed.
Yeah, sorry, I did think that might not be your your specialist subject, Rebecca, but we can follow up with that one and get it explored offline. I think we have had a couple of other questions along similar lines in some of the previous talks as well. So we will cover those off. So I think I will probably draw this to a close. What I will do, if people still have questions, I will leave the meeting running for another 5 minutes or so that you can put questions into the chat. And then Rebecca, Eve and Emma will follow up on these at a later date, and we will kind of publish that online, kind of a menopause FAQs section, and we will email everybody when that's available. We are getting a few questions in the chat as well about the recording for today's talk. As you are registered on this talk, everyone here will receive an email letting you know when that is available. A few people asking for the previous ones as well. So what I'll do when we send that email out, I'll include all the links to all 3 of the talks so that you've got that to refer back to and have a look at again, should you want to revisit them. And hopefully that will be within the next couple of days, we'll get that out. But I think I will draw this to a close now and say thank you very much to Professor Rebecca Hardy for today's talk. And that's been very, very interesting, and a lot of really positive comments in the chat. So I think everybody's really valued that. So thank you. So I will now draw this to a close, and yeah, do put questions in the chat for the next couple of minutes if there are any you'd like to follow up on. So thank you very much and enjoy the rest of your day.